panel presentation for our 2001 NSDA Symposium, Treatment Paths for Spasmodic Dysphonia and Related Voice Conditions. And I'd like to introduce the president of our organization, Mr. Charlie Reavis.
Thank you, Kim. A real pleasure to be with all of you today. Great to hear the first panel. What a terrific way to start our symposium this morning. And so I'm just delighted to be a part of this panel to talk about treatment paths for spasmodic dysphonia and related voice conditions. So I will just start by asking each of the panelists to quickly introduce themselves. As Kim said, I'm Charlie Reavis. I serve as president of the organization, and I have AD, SD, and have had for over 20 years. Generally, Botox works pretty well for me, so I'm very fortunate in that respect. So we'll start with Julie. Would you introduce yourself, please?
Sure. Good morning. My name is Julie Barkmeier-Kraemer. I'm a speech-language pathologist and professor in the Division of Otolaryngology at the University of Utah and the clinic director for our Utah Voice Disorder Center and the director for the Voice, Airway, Swallowing Translational Research Lab. And my interest is in neurogenic voice. So I've I would say spasmodic dysphonia, which we now call laryngeal dystonia, was really what got me interested in going on for my PhD. And so I've had a long-standing interest in this particular voice challenge, and most recently have been focusing my interest on distinguishing between those who have essential tremor or voice tremor and those who have spasmodic dysphonia. So a lot of my more recent research has been focusing on trying to do differential diagnosis in the clinic.
Great. Thank you, Julie. Joel.
Hi, everyone. Joel Blumin. I am a professor of otolaryngology and laryngology at the Medical College of Wisconsin. I'm the division chief. I've been interested actually in spasmodic dysphonia for a very long time. In fact, I first did research with Dr. Barkmeyer-Kraemer about 30 years ago, so I can attest that I've been interested in this for a long time too. I've been part of the NSDA as a medical advisor for I think about 20 years now too. I'm a physician and take care of a lot of patients with spasmodic dysphonia. I do both Botox injections and surgery as well as other things. So,
thanks, Joel. Bonnie.
Well, I'm a little bit different than my other colleagues today. I am in a small private practice, all voice, in Florida. And I was at the University of Illinois College of Medicine Medical Center for about 26, 27 years. I was the director of the Division of Speech Pathology there. And starting way back in the 1980s, seeing patients with spasmodic dysphonia, they wanted to meet other people and talk to other people with SD. So we started the Spasmodic Dysphonia Support Group of Chicago. First meeting, I think, officially in 1990. I was a sponsor coordinator of that for over 10 years. After relocating to Florida, I attended the Fort Myers Naples Support Group for a while. And so I see patients, some patients with SD in my private practice. And I have to say, I am currently seeing a patient with vocal tremor using Julie's techniques, and they have been very, very helpful and successful. So it's really been great to be on this panel with her.
Thank you, I appreciate it. Michelle.
Good morning, everyone. My name is Michelle Donovan. I am an attorney in the state of Michigan, and I was recently diagnosed almost 2 years ago. I am right vocal cord paralysis, idiopathic. And I also monitor a Facebook support group for vocal cord paralysis support group. And I'm honored to be here. And part of what I like to do is raise awareness. And it's a small group of us, but we all seem to have banded together to share our resources and our stories and techniques. And I'm so thankful to be on this panel with you and to gather more information as well.
Thank you, Michelle. Appreciate you joining us today and being part of the conversation. Erik.
Yeah, hi everybody. My name is Erik Laurence. I live in the New York area. I was originally diagnosed with adductor spasmodic dysphonia. Oh, it was back in the 90s. I think I went to see Dr. Brin in the early days. I had a Botox shot. I think it was a big dose because I lost my voice for about 3 months. But after that, it came back and it was pretty strong and it was good for about a year. Then it started to get worse again. I think I was in denial for a long time, and eventually it got bad enough that I had to do something about it. And because at the time I was living in China and Botox was not really an option for me, I heard about the surgery that Dr. Burke was doing in California, and I had that. That was 10 years and a few months ago. So it's February 2011. You know, in a way similar to my original Botox experience, I lost my voice for a long time, about a year that time. That was tough to say the least. But since then, it's come back. It's been strong. The last 9 years have been great. I've kind of drifted away from the SD community because of it. I mean, I would say that my voice is not 100%, but it's a good solid 95%, and I'm happy with it. And most times I don't even think about it. And I'm grateful for that. And I'm just here to share my experience. I think that surgery is not for everybody, but for some, I think it does make sense. And it certainly was a good thing for me.
Thank you, Erik. Appreciate that. Appreciate you being with us today. Bruce.
I am Bruce Menk. I live in Denver and as just recently retired as an attorney, Michelle. My practice was essentially trial work. And when I was 41 years old, I got a sinus infection, and then my voice started getting tight and strangled. And I went through a long period trying to get my condition diagnosed, and was diagnosed with a lot of things I didn't have. I got lucky. I got working with a speech pathologist, and after working with me on alleged nodules for months and months, he said, "I don't think you have nodules. I don't think you ever had nodules. I think you have spasmodic dysphonia." And the NSDA was just getting started at that time. And I happened to connect with them and their publications and found Dr. Trong out in California and saw him first in 1989 and was treated with Botox then, and probably have had 50 Botox treatments over the years. Started out, got about a 3-month good result. And I'm now more in the year to 14 months between injections, and it saved my career. I think the one thing that I also had, all that speech therapy was very useful, even though, because it got me a diagnosis, but it also gave me some techniques that I've used over the years to particularly initiate speech. Mine is adductor, and that's helped a lot. And I've also used some biofeedback and some relaxation, mainly audio tapes, because I feel like stress makes things worse. And if I can get some of that out of my system, it's better. And hopefully retirement will work in that regard as well. But I was the president of NSDA in the late 90s, and I have just gone back on the board a couple of months ago. And think the organization is really wonderful because of things like this and all the resources that just weren't there 30 years ago.
Bruce, thank you. Terrific comments. So I know we have a lot of questions from the audience, from participants. So we're going to jump right into those questions. Kim, what's the first one?
Sure. And I also just want to mention, you know, as part of our organization, we have expanded our mission to include related voice conditions. And that is one of the reasons we are welcoming Michelle on with vocal cord paralysis, because, you know, we're trying to serve more people that have muscle tension dysphonia, essential tremor, vocal cord paralysis. So this will be a little bit of a different approach for us and a little bit of a little mix in there, because at the end of the day, the impact of living with this voice condition is the same. And some of the treatments and the physicians and the healthcare professionals are similar. So, you know, we appreciate everyone being here. So, so now on to this first question. Do many people with SD also have essential tremor?
Julie,
please
take that one.
Sure. Yeah, thanks. That's a great question. The answer, I think, has to be we don't know, because we have not really done a great job of systematically clarifying the characteristics of those individuals we assess in the clinic in a systematic way. We just completed a project where all we did was a retrospective chart review, and wanted to ask the question, if we apply the new updated classification criteria for tremor, which would include essential tremor, how would that then result in the same or different outcomes from those individuals in the chart who have the diagnosis they have? And we looked at all comers in our hospital system who are diagnosed with vocal tremor. And we had a lot of missing information. So what we came away with was learning that we haven't been very systematic, like a movement disorder specialist might be, in systematically charting the characteristics we assess. And we came out from that study with just a much smaller cohort than we started with. We had about 300 people we started with, and we ended up with about 111 that actually had a full documentation of their problem. And so the chances are high that essential tremor can co-occur, but in our literature with spasmodic dysphonia and co-occurring tremor, I highly suspicion, based on my own work at different locations I've worked in the last 30 years, that individuals who do have vocal tremor, where they end up with voice stoppages or breathy breaks that occur rhythmically, may be getting classified as having spasmodic dysphonia when what they really have is a severe tremor. So we're actually embarking on a prospective study right now. We're funded by the NIH to look at all individuals who have essential tremor and to evaluate those with and without vocal tremor, plus the work we're doing with all neurogenic voice disorders to add a systematic prospective approach in our clinic. So we're hoping in the next year or two, we'll be able to report out on that. But we highly suspicion that there may be individuals who have spasmodic dysphonia and a co-occurring essential tremor, or tremor that would be classified as having a dystonic etiology. So we hope to report out on that and have more clear information. It certainly can happen. Pretty much if you have a neurologic problem, it's very possible to have co-occurring neurologic problems as well. I think that's been reported on in the past, where Andy Blitzer reported on individuals who were 20 years out from their diagnosis of spasmodic dysphonia. And within 20 years, you have a higher probability of developing other problems. But the answer is we don't really know exactly what that proportion is right now.
Thank you, Julie. Joel, anything you want to add to that?
I agree with what Julie says. Maybe, I don't know, same thing said differently, is there are patients who have essential tremor that can have breaks. There are patients with laryngeal dystonia or spasmodic dysphonia that could have tremulousness. whether or not we're talking about spectrums of the same disorder or different disorders is the thing that's kind of up for grabs. Management tends to be, from our point of view, tends to be pretty similar. We treat breaks and hyperfunction in a certain way, and it doesn't matter where it comes from. We treat tremor in a way. So it matters how we classify these things, but treatments tend to kind of be a little more overarching, at least at this stage, because our treatments are unfortunately broad strokes.
Good. Thanks, Joel. Kim, next question.
What can you tell us about the availability and success of the SLAT surgery? Is it recommended for people over 70?
Joel, you want to take that first, and we'll let Erik.
I guess I'll field that. So the indication is really, that a patient has adductor spasmodic dysphonia. I would say that they don't have a lot of tremor or tremulousness, mostly because that's not really a dry the operation. And there are some patients who have had both or overlapping tremulousness, and that seems to be less affected and they're more noticed after the operation. Obviously, the patient wants to have it. It's an option for treatment. It's certainly not the only treatment. Most patients are well treated or managed with botulinum toxin and chemodenervation. And then over 70, we approach that cautiously. It depends on how healthy an over 70-year-old is. There is evidence in the hand literature on reinnervation that reinnervation over the age of 65 or so is less reliable. That said, that hasn't necessarily panned out to be true in the larynx. It's really up to sort of the patient and the physician and sort of what they agree upon. I would say, all that said, the older patients, somebody maybe above 70, might have a little bit more of a hard recovery period with the swallowing issues that come after the operation. Almost everybody after the operation has very, usually temporary, but dysphagia or swallow issues where they're, I always tell folks it's like the biggest Botox shot of their life, where they are potentially choking on food and having to think about what they're eating. For most patients, that's a big issue for a day to a week, with something that they notice for about a month, and then after a month it's gone. It seems to be gone. In older folks, that could be a little bit more protracted.
Thanks, Joel. Erik, you have experienced the surgery. Any other observations or thoughts in addition to what Dr. Blumin was talking about?
Yeah, I mean, I did experience the surgery. It overall was a good experience. I did have trouble swallowing for a few days, but it wasn't terrible. And I was able to swallow solids just fine. It was liquids that were more challenging. And the solution to that is to put this powder in liquids, or to eat or to have a smoothie or something like that. I forget what the powder is called, some kind of a thickening powder, but that goes away after a few days. The biggest challenge is you're gonna lose your voice for months. I mean, it could be, it's at least 4 months, and it could be 6 months. In my case, it was, my voice started to come back after 9 months, but then I was squeaking all the time. And so that was a real challenge. You really have to devote a year to your life if you want to solve this problem. And for me, it really was a solution. I mean, it's to the point where I just don't think about spasmodic dysphonia anymore. So I recall when I had it, I had spoken to a few people who had it at older ages. I don't remember exactly, but I think, as Dr. Blumin says, I don't see any big reason not to, but you should, consider your other health conditions carefully with your doctor.
Good. Thanks, Erik. Kim, next question.
We have actually a follow-up for Erik. Your voice sounds great. Curious if you experience any problems with your voice. How do you find talking on the phone and when there's background noise? Any issues there?
Really none whatsoever. As I said before, I pretty much have forgotten about spasmodic dysphonia. I don't get nervous in social situations anymore as I did when I had some problems with my voice. When I say that my voice isn't perfect, it means that, you know, every now and then I might feel a little bit of of myself tripping up on my words. I mean, I can't sing. It's been documented that for singers, having this surgery doesn't necessarily restore your ability to sing, but I could never sing before. So that would have been amazing if I was able to sing after this. So, you know, really the phone is easy, background noise is easy, and you know, background noise was hard for me. It used to be tough in a restaurant. That was one of the worst things. The phone was less difficult for me when I had spasmodic dysphonia, but restaurants were hard, background noise was hard, and now it's, you know, now it's fine. I really, you know, I simply don't think about it very much.
Good. Thanks, Erik. Next one.
Let's see. What do you recommend when Botox stops working?
Joel.
So, you know, for one, there is definitely an art and a science to botulinum toxin injections, and some days it's one or the other. When during a given clinic, some days I feel like I've lost the art, and some days everything's right on. But we actually did a paper that showed that about 95% of our Botox injections resulted in what the patient call success, and we were comparing techniques, but for both techniques it was about 95%, which also means that about 5% of the time we weren't achieving success. Now, why weren't we achieving success? Sometimes it's the dose. This gets into the art. Sometimes it's the dose. Sometimes it's the dose placement. Sometimes patient has a cold or a upper respiratory infection. That seems to have some impact. So there's definitely some nuances to this. You know, Botox really does work well in the great majority of patients. And I would say the first thing when Botox is not working wouldn't necessarily be to give up on it, but to bring that up to your physician and say, Botox isn't working. And then they'll say, you know, why or what's going on is, you know, I'll ask, you know, did you have too much breathiness? Did you have a Minnie Mouse, Mickey Mouse, squeaky voice? Did you have no effect? You know, did you have swallowing issues? All these kinds of things. And so I really try to hone down what went wrong, so to speak, with the injection. And then there might be a dose adjustment or a technique adjustment where we might have been delivering Botox to both sides, and we might switch to unilateral dosing. We might go up in the dose, we might go down in the dose, we might go asymmetrical in the dose. There's a lot of nuances how to do it. I like percutaneous, meaning going through the neck, but every now and then there's somebody who does better with through the mouth, going sort of around the corner. So there's a lot of nuances to that. And as somebody who does surgery, my first option is not to say, well, you need to sign up for surgery. In fact, quite the opposite. We usually try to troubleshoot the botulinum toxin injection. Now, going back to the original question, what if Botox really doesn't work, or it's just not the solution for the patient? They've tried, and their physician has tried, and they don't want to do it. Well, that's where we do talk about some of these other things like operations. The Slat operation is probably the one that's most commonly done in the United States. Frankly, I think it has the most data behind it. It's all retrospective chart review, but it's the one with the most data. Thyroplasty is done more in Japan, and there's some in this country, and there's data behind that. And there's myectomies, removing parts of the muscle. Again, another technique, a little less data, but all seem to be effective in certain patients. Hopefully I covered it.
Good, thanks, Joel. Bonnie, just a little bit of a follow-up. Do you see patients who come to you and say, boy, I've been getting Botox injections for some period of time, maybe an extended period of time, and they decide to try more specialized speech therapy?
I think it kind of depends, as Joel was talking, you know, why is Botox not working, and the voice they're left with, how severely impaired is it? I think voice therapy, certainly in more mild cases, and I talk about this in my talk, seeing someone who had Botox, and the after effects were much greater of an impairment than just her SD alone. So very, very mild case. And in that case, certainly, I think there's a lot that we can do in voice therapy to comprehensively evaluate the voice and speech. And they may be doing certain things that are not helpful. Obviously, all the techniques we've been talking about really deal with the spasms themselves. And voice therapy is not going to necessarily change that. But the responses to those spasms, the compensations people are doing, that's where we can be fairly effective. And if those are kind of overtaking the person, then voice therapy can do a lot there. So I have seen some patients who decided to stop their Botox. We had a woman on the panel before us saying she just stopped. And sometimes the voice maintains pretty well. Not quite sure what the reason for that would be, but they do okay. And then they may be interested in doing something else, still having some treatment, but not necessarily one of the other ones that we've been talking about. And voice therapy might really be great for them.
Good, thanks, Bunny. And I would just add for all of our participants, we have a pre-recorded video of Bonnie talking about some of her techniques in voice therapy. So I would encourage all of you to look at that. And she has a lot of good information there in that pre-recorded talk. Kim?
And I'll just add, we actually, the pre-recorded talks are available on our website and on our YouTube channel. And there are quite a few. Dr. Barkmeyer-Kraemer also recorded one, and some of them on our research panels that will be coming up next. So we appreciate those recordings. And we also included some of our recordings from our 2020 symposium, because they really kind of help to round out these topics and such. Again, links for that is all available on our website, and we'll be posting that link again for dysphonia.org. So we're going to switch gears a little. And what is the most common cause of vocal cord paralysis, and what's the treatment options available?
Joel, you want to start with that, and we'll let...
Sure. Common causes, and I think it depends on the paper, but I want to say about 50% or so are what we call idiopathic. Idiopathic means, well, the joke is the doctor's an idiot and the patient's pathetic. If you guys have ever heard that before. Idiopathic means we have no idea. And we'll say things like, it might be a virus. And actually, in some cases, patients will say that this all began with a bad cold or bronchitis or something like that. But the reality is we've never been able to at least effectively trace it to a known virus. So idiopathic means idiopathic. We just don't know. A large proportion of patients that we see also with paralysis comes from, frankly, from surgeons. From operating near the nerves to the vocal cords, either with like a thyroidectomy or the left vocal cord, the left recurrent nerve, the nerve to the vocal cord actually goes into the chest. And so we'll see it with heart operations or different chest operations, neck, spine operations, things like that. So I would say in my practice, it's probably about 50-50. Patients are either surgical or idiopathic. There are also occasional cancers and things like that. As for cause, there is a workup that we do when we see a new patient without a known reason to look into the source. Standard typical approach is to get a imaging to a CAT scan, basically to look if something's pushing on the nerve. And if the patient doesn't have a reason and nothing is pushing on the nerve, then we generally say that it's idiopathic or we don't know. Idiopathic paralysis, and there's different models and things like that. If it's going to recover, it can recover in 6 to 9 months. Textbooks will say up to 1.5 years. But most of us think it's probably a little bit shorter than that on average. That's just cause and workup. What was the other question? What are the treatments?
Just a quick overview of
quick overview. The goal, so when a vocal cord is paralyzed, 2 vocal cords come together to form a valve, essentially. And when the one vocal cord is paralyzed, now a lot of you with spasmodic dysphonia know about this from Botox injections. it becomes weak. The valve is weak, and you kind of have a breathy voice, or this kind of Minnie Mouse voice like this. And when that valve is weak, you have that hoarse, weak voice, and you could have swallowing issues as well. Our goal is to bring the vocal cords together so that they're able to touch and reform that valve. And there's a variety of ways we can sort of manipulate or push the vocal cord over. We can inject something in it to plump it up. We can physically move it over and hold it in place with a small implant. We can move it over and hold it in place with a suture, which is called an arytenoid adduction. We actually manipulate the joint that the vocal cord is attached. And then there's something called reinnervation, where we can actually plug a new nerve into the old nerve, and it doesn't wake the voice box back up. Unfortunately, it's not a time machine. Reinnervation actually just provides tone to the muscle, so that the vocal cord stays a little bit more plumper, so that it touches the other side a little bit better. And those are the main options.
Okay.
Yeah.
Okay, thanks, Joy. Michelle, you want to talk a little bit about what you experienced the last couple of years and treatment options that you have done?
And Michelle, before you begin, we actually had a question addressed to you that you could cover with this too. For Michelle, being recently diagnosed, how does she deal with the day-to-day work stresses, the days that I have a lot of team Zoom calls and I am physically exhausted at the end of the day? So it'd be great. I figured you'd cover that too, but I just want to roll that in there.
That's going to be my new novel I'm going to write. So like Bruce, I'm a trial lawyer as well. I've been practicing for over 20 plus years. And what happened for me is, Joel had stated, mine started with and Bruce as well, with a sinus infection 2 years ago. We had very high temps here in Michigan, 100 degrees. I went to my regular physician and I was very congested and a couple rounds of steroids, and I still couldn't catch my breath. I couldn't breathe. So I went to my ENT. I was already a patient of Lakeshore ENT. So I see Dr. Adam Rubin, and I've been seeing him since the beginning. And I also maintain my voice therapy. I have not stopped that. So for the last 2 years, I continue to do. So when I go, I've had all the tests, the MRI, brain scans. I was diagnosed with Hashimoto's. I thought maybe a nodule was pressing on my nerve, but no such luck. How do I deal with my, so what I do, I have an injection. I had Symmetra pre-pandemic, and that wore off very quickly. And then when our restrictions were lifted last June, I think I was Dr. Rubin's first patient, because for us, we can't breathe. You can probably hear it a little bit. I'm like, grasping a little bit for air. I had my second injection in June of last year. I had Polarin, mostly because that's what the hospital had when I had to go in, because their medical supplies weren't ordered during COVID. It's been holding, it's worn off. I just had a visit with Rubin last week. So as Joel had said, for us, you either continue injections, you get a implant, a prosthetic, the thyroplasty, or the reinnervation, which doesn't make the nerve work either. Hopefully my goal is that there's more research and we can stimulate the nerve somehow to make it work. We have a joke among the attorneys that this is a lawyer's affliction that we get. I have a couple attorney friends that are idiopathic and have this, but they've hid their condition and nobody knew about it. But for wearing, my mask, that I have a vocal cord disorder, it's not something that I openly discuss or want to talk about, because for me, it's a grieving process and it is still new for me. But with COVID, it's raised a lot of awareness. How do I deal with this on a daily basis? I also am an adjunct at my law school, so I do a lot of talking. What I do is I structure my day around Zoom calls, court appearances on Zoom. I wear a microphone, actually it's an amplifier, so that my voice projects more. I drink my water so that I'm hydrated all the time. I have not had a glass of wine in 2 years. I probably need a whole bottle after this pandemic and dealing with this paralysis. But I stay hydrated. I take all my decongestants, my antihistamines, so that I'm dry at the same time trying to lubricate. For me, what has been able to manage this condition is my SLPs. They've been a godsend for me. You know, I do go in and I see my doctor, you know, for the tests and the scope and all that, but the SLPs truly have given me my voice back. And what I do is I walk around with my little notebook with all my notes, my bubbles. I blow bubbles all the time to take a break and relax my throat. So for me, it's just managing, and honestly, it's a grieving process. I think, like Erik said, you are all of a sudden diagnosed with something that affects your essence. You know, how do you deal with this? So I can't feel sorry for myself anymore. You know, I got to pick myself up and just raise awareness. I started a new firm, and during the pandemic, and I was talking to them, they didn't know that I had this condition. We were on Zoom. When I went into the office, I had my mask on, and they were like, oh, you know, what's that all about? And make a long story short, they put it on my bio. So I was mortified that my bio goes out to the world with all my, you know, professional accolades. And on the very bottom, it says I have vocal cord paralysis. And I was just like, I don't know if I want that out to the world, but it's okay. So it's out there now. And I'm just thankful for the medical profession that we have that can continue to do research and, you know, find something that we can manage. There's no cure. This is something that there's no cure. We can't take a pill. And even the surgery is not successful, but you have to have the tools to learn how to manage. And, you know, it really is support. It takes a village, you know. My family and friends don't get it. So it's only when I talk to my SLP and cry to them and, you know, my Facebook group. But if you don't have this and you're not in this world, it's very hard to appreciate what we all go through. And when I heard Erik talk, and my heart just goes out to you because of the surgery that you've had, and you know, I'm going to get all choked up, but you know, my heart goes out to everybody like us that has this, that please somebody find a cure for us. You know, can you make my nerve work? Can you take a stem cell from my hip and stick it in my throat? I don't know, but make it work, you know, but I know it can't. So sorry, lawyers, we just talked. You should just mute me at some point. I'm sorry.
Oh, good, Michelle.
Sorry, Charlie. You know, I go on and on.
And I think there was, I wanted to jump in here real quick. I think there was a question coming in. What are SOPs? I think you were saying your SLP, the speech language pathologist. You were referring to us as
my
SLP.
Sorry, yeah, my SLP. Sometimes
I think somebody got that and said, "What are SOPs?" And I think that's what they were referring to.
Yeah,
so
my SLPs. That. Sorry, my SLPs.
Thank you.
Sorry.
Yeah, Kim and I had an opportunity to learn about Michelle and meet Michelle and her Facebook group last year. And so we've had some good conversations. We did a Zoom call with Michelle and her group, which was just terrific. And one of the questions that pops to mind for me, and maybe Joel and Julie and Bonnie, you guys can respond to this. How prevalent is vocal paralysis? And especially, I know, Joel, you mentioned, and I've heard other laryngologists say that maybe 50% of vocal paralysis is idiopathic, but just how prevalent is vocal paralysis?
I don't know the actual numbers, but I mean, I would say in an average week, I might see several, you know, probably between 2 to 5, maybe even more vocal fold paralysis patients that are totally new. And then, you know, with respect to SD, you know, that's more like 1 or 2 months that are new. You know, so it's much more common.
Okay, Julie?
It makes up a pretty big part of my caseload. Sorry, Julie, I jumped in on top of it.
No, that's good.
And again, I can't give numbers because my caseload is relatively small, but it's pretty common for me to see.
Yeah, I think among neurogenic voice experts, they populate a big part of our caseload. I think Seth Cohen and Nelson Roy did a study where they looked at various diagnostic voice problems for another purpose. And when I looked at that, I think paralysis, paresis, was less than 1% of the overall caseload of voice disorders. And voice disorders can occupy about up to 6% prevalence on a speech language pathology caseload of voice experts, of which there are less than 1% of those among all speech language pathologists. Just on that note, I'd like to say too, make sure you reach out to someone who is an expert. So there are over 200,000 members of ASHA, the American Speech Language Hearing Association. Less than 1% of them are experts in voice. The large, vast majority of my profession do not specialize in voice. So you want to make sure when you find somebody, you go to somebody who's an expert. And then I think similarly, we did an estimate of the number of members, and Joel is much more of an expert on his own profession than I, but the membership numbers of the American Laryngologic Association were also a very small proportion of the overall Academy of Otolaryngology. Joel, is that your experience too? That
well, the actual ALA is American Laryngologic Association is limited to I think 150 members currently. So
yeah,
that are actually sort of, and that's our specialty society. Probably the highest level of our academic specialty society for people that do laryngology. Yeah, this is specialized stuff, and that said, there are a lot of us now out there and around. That wasn't necessarily the case 20, 30 years ago, but now there's a lot of us around, and you can find us through either, through any of the websites, the NSDA website, the ALA website, the ASHA website, we're out there.
Yeah.
So I saw a question that came across, and I think this would be a good time, Joel, Julie, and Bonnie, if you guys could comment on. And somebody was asking, what are the differences between spasmodic dysphonia and vocal fold paralysis? Joel, you want to comment?
Sure. Well, they're different pathophysiologies. The source of laryngeal dystonia, spasmodic dysphonia, as most of you know, is unknown, but probably is in the brain. And probably has to do with some of the different communication pathways in the brain, and the way the voice sounds is a symptom of that. Paralysis usually is a problem more times than not of the actual nerve going to the voice box, where that nerve is not functioning. So you actually have a weakness with the nerve. So that one, the reason for the problem, even if it's idiopathic, meaning even if we don't know what caused it, the reason for the problem is more delineated. They're different problems. They both result in voice problems. They both result in folks having difficulty communicating. Effort of voice, that's kind of a big deal, and that's actually a lot of what we manage. A lot of what our my speech pathology colleagues manages is the effort and the work of speaking, and that's one of the things that we hear from our patients. The hoarseness is a bother, but it's really the work that they're doing to talk. So that's where all this stuff overlaps.
For different reasons too.
Really? Go ahead.
Yeah, I was just going to say, if you think about the continuum, so Michelle was talking about the difficulty projecting her voice, and it's because the valving at the larynx where the voice is generated is weaker, which is something those with laryngeal dystonia experience after a Botox injection, where there's also a weakness. But with the symptoms that we're treating with Botox, laryngeal dystonia usually results in increased effort because there are spasms that either pull the vocal folds apart, resulting in a rush of breathiness, or cause the vocal folds more commonly to spasm together, creating an obstruction to the airflow. So they're kind of different. One is more intermittent with spasms, as Joel said, coming from brain patterns of production, and then peripherally, the nerve injury for vocal fold paralysis creates difficulty getting the vocal folds to come together. And actually, idiopathic vocal fold paralysis is another line of my funded work. We're trying to understand idiopathic causes, and we're now finding that one thing that really robustly distinguished those individuals who had the idiopathic vocal fold paralysis from normal age-matched controls was that the aortic arch showed that it had more dynamic pulsing. And we're now studying more carefully that, just to see if there's something about the vascular system where that nerve wraps around the aortic arch in the chest, in the thoracic cavity, that might be a contributor that might be what could cause what we call idiopathic vocal fold paralysis. And so the degree to which the nerve gets stretched or compressed, it can either damage the nerves so they cannot regrow, or damage them so they are able to return to regrow out and go back to the musculature that got affected by them being disrupted. So we're hopeful that within the next 4 years, we'll have an answer to that.
Terrific. Bonnie, anything you want to add?
No.
Erik, I think you had a question or a comment a bit earlier.
All I was saying was that, Michelle, your voice sounds terrific. I don't know much about vocal fold paralysis, but does it always sound this good, or is it because of treatment that it's now sounding good, kind of the way that with Botox, sometimes you're good and sometimes you're not, or what's the secret?
I wish I had the secret, Erik. Your voice sounds good to me too. No, this is, well, number one, this is not my normal voice that I have now, but I've learned through my SLP, what I hear in my head is not what you're hearing. No, it's more gravelly and grainy to me, and it comes and goes. So my voice is not a continuum. During the day, I have highs, lows. I have a little sign that says I need a voice rest that I have to wear around my neck sometimes, or when I come home at the end of the day, I just don't want anybody to talk to me. I do a lot of texting, but my voice is not consistent, where I don't know if your SD makes your voice consistent with the type of surgery and Botox that you've had, where paralysis, we're like this all day long. Yeah. So see, I just dropped, and I'm not supposed to drop. I'm supposed to lift and talk up like this, right? So it's a lot of memory up here to retrain to lift up, but no, it goes like this all day.
One of the interesting things that I found through this journey is before I had the surgery, I was very cognizant of the limitations of my voice, and I was very self-conscious about it. And some people noticed and other people didn't. I mean, I think I tried to ignore it up until the point where the surgery was imminent, and I knew that I was going to lose my voice for about 4 months, which turned into a year. But, and so I had to tell people that I was really going to lose my voice. And, you know, some people said, oh yeah, I had heard something with your voice. And other people had said, oh, I never knew there was anything wrong with your voice. And so I think that to a certain extent, if people are able to understand you, even though you're struggling internally and it's a challenge for you and you're unhappy with how you sound, and you know, most people kind of don't notice.
Yes, we notice more because we're more cognizant of our own body, if you will.
Right. Of course.
But you know, I'm interesting, Erik. Can you project? Can you yell?
Yeah, I can shout as loud as I want these days. Really,
I envy that. See,
well,
we can't. Yeah. I can't project. I can't yell.
Yeah, I couldn't for a long time. I mean, the recovery of this surgery took a long time. It really took a year, but for me now, especially 10 years out, it was completely worth it because I've never done anything since. I've never had a Botox shot, and I don't, you know, it's a cure. I know it's not a cure technically, but for me, it was a cure.
No, that's wonderful. I wish that there was something that
and I hope that, I hope that you'll find yours.
I think, Michelle, you commented a few minutes ago about whether Botox, you had the ups and downs after Botox injections. And I can tell you in my case, you do, but it's certainly, for me, the ups and downs are less noticeable to others and to me when I get a good Botox injection. Bruce, what about you?
It's the same for me after I get an injection, and I've been getting the same dose for years and years. But it seems, even though the dosage is the same, sometimes it works better than others. I don't know whether the medicine itself is not consistent or what it is, but if I have a nice long breathy period, maybe 2 to 3 weeks after the injection, I know I'm going to get a longer good voice. And actually, when I have the breathy period after the shot, it's easier for me on the telephone and that sort of thing, where I would struggle after an injection when I was practicing is if I had to be in a meeting or in a restaurant, for example, with and this is something you figure out when you have this. There are so many hard surfaces in restaurants these days, and there is so much ambient noise that when you're in that breathy period, you're going, this is nuts. Why do they build places like this? But you learn to try to stay out of the settings where you have to project a lot for a while. And then a lot of people don't, I'm lucky, a lot of people don't know I have anything wrong because I get a good result. Yeah. And I was able to practice and try pieces. I mean, I'm really blessed. And not everybody is that way, and not every injection is that way. There are some that you go, I'm breathy for 3 days, and a month later I can start feeling it, and I go, oh, crying out loud, why can't we do better here? But it certainly beats the heck out of no treatment, because that's just, it's too frustrating. It's too, you can work around it, but you've really lost something. And I know there are people that are hesitant to get treatments, but if nothing else, spend some time with a good speech pathologist. And there are a lot of things that you can do to help with the symptoms that don't involve invasive procedures. Not that the procedure's that bad, and I liken it to dentistry, perhaps. It's quick, and it's not particularly painful. Then it depends on the technique Joel might want to comment on the different Botox techniques that different practitioners use. I mean, some place it just anatomically, other ones use scopes and all of that. And my doctor happens to have an ENT use a scope, and so he can see where the injection's going, and an EMG that he can tell when it's where it's supposed to be, and I like that. But people don't think that's necessary.
I was going to make a comment that you actually said something where you hear like somebody that gets 3 days of breathiness, and that sounds horrible to you. It's interesting from my side, seeing a lot of different types of patients. There are some folks, well, I should take a step back. In my mind, the goal should be zero breathiness and a ultimate fluent voice all the time. That's really our goal. That said, Botox does have these ups and downs, and there are some patients that are intolerant of them, and we tend to give them lower doses, sometimes a little more often. There are other patients who don't actually mind a whopping dose, and when they come back, I'll say, how did it go? And they said, oh, I had 3 weeks of breathiness. And I'm like, oh my. But they're like, no, it's fine. And then they don't see me for 6 months. And so there really is a large variety of what patients find accepting. And that kind of goes to the important part of, to communicate. As somebody who delivers injections, I need to know what's going on. I also need to know what you want. And if you want, if you don't mind the breathiness and you don't want to see me very often, yeah, I guess that's okay. Would it be what I choose? No. I have one patient who's kind of an academic, and it's interesting when she's in meeting season and actually doing a lot more public speaking, she sees me more frequently, gets really tiny doses. When she is not doing that, she chooses to have a bigger dose and not see me very often. So it's very interesting. Talk to your providers.
You know, what's interesting is the difference with the SD and the VCP, because with VCP, we get a shot to get rid of the breathlessness. So I get my injection the next day. As soon as I get my injection, I wake up, that immediately has been able to close the gap that I'm experienced. So it's the opposite a little for patients like me, because I can't wait to get the shot so that I can breathe, if that makes any sense. And just the differences with the two different types of disorders that we have.
Right, good point, Michelle. I would also add a little bit to what all of you guys are talking about, what Joel's talking about. You know, we are abundantly blessed with those of us with whether it's SD or some other type of voice condition to have such a dedicated and committed group of healthcare professionals to help us and to take care of us. And one of the things that I would encourage some of you who perhaps have tried Botox and for whatever reason it didn't work for you, talk to your laryngologist, to an SLP. They're going to tell you that, hey, you know, if it's not working, I'm just not sure what's going on. They will suggest to you to perhaps go see another physician. I mean, these are dedicated, committed people. So don't give up on it because it doesn't work with a particular physician. Talk to your laryngologist or your SLP and about perhaps seeing someone else to give it a go. And that's part of what Joel was talking about, the relationship that we have with the healthcare providers, those of us with these voice conditions, is very different than the relationship you probably are ever going to develop with most of your other physicians that you see in your lifetime. This is a teamwork. It's the patient with a voice condition has to be a member of the treatment team. You can't be passive. You have to get engaged. And as Joel and Julie and Bonnie have talked about, we work together, patient and provider, to be the treatment team. So just to kind of keep those things in mind and perspective. So, Kim, next question.
We had two more about Botox and for Dr. Blumin. And I know it may be a longer answer than we have time for, but we'll touch on it a little bit. The first one was about the year-long benefit from a Botox shot when we know it dissipates after 3 months. Does that mechanism have any implications on future treatments?
I don't know. I actually don't know if it has any implications on future treatments. I guess it might. The average clinical benefit of Botox is about 3 months. We actually did a study, this multi-center study to look at diagnostic implications for spasmodic dysphonia. And we started scoping our patients as part of the study routinely at 3 months or so after, because we wanted them to be washed out of their Botox when we were gathering some of the data. And what we discovered, although I would say a lot of the laryngologists sort of knew this, was there was still some weakness of the vocal cord that we can see, but it wasn't clinically, meaning we hear what the patient feels and what we hear wasn't really as affected. So the clinical effect of Botox goes away in 3 months, but Botox itself might be there longer. The other sort of issue is the way Botox works, to my understanding, is that it irreversibly binds the neurotransmitter apparatus at the end of the nerve that communicates with the muscle. Once that happens, that never works again. And the reason why you recover from Botox is essentially healing. Your body recreates these vesicles, these little packets of communication molecules. And that period of time for your body to make these new, what we call motor end plates, that's the time that the Botox lasts. So you're essentially healing. And as we know with other things, healing could be different for different people. You can, heal a little cut in a week or 2 weeks. And so the same thing I think happens with Botox, in that some patients will get 3 months, some people will get 6 weeks, some people get 6 months. And so there's a little bit of a variety. I think that's kind of a overall summary.
Yeah, good, Joel. I know there's, I've noticed some questions coming across too about various other treatment options, what some of the research teams may be working on. We're going to talk about some of those in the next panel. So those of you with those questions, if you would hang on to those, and we will certainly attempt to get to those in the next panel.
And Charlie, I have collected those questions regarding the new treatments, and so we can address those.
Super. Thanks, Kim.
I think we're coming to the close of our panel, so we may want to do kind of a roundtable and wrap up.
Yeah, let me just, before we quickly do that, let me add for the participants, I saw some questions about where to find healthcare providers in certain areas. Go to our website, dysphonia.org, go to our healthcare referral listing. We work really hard to keep that updated. And if any of you find a physician who treats a voice condition that we do not have listed on our healthcare referral, get back to us, let us know, and we will contact that healthcare provider and ask them, do they want to be on our listing? Because we don't put anyone on there who, for whatever reason, might not want to be listed. So Kim's putting that list up for you now, and the access to it on our website. So let's do a roundtable, and we will call it a wrap here, folks. Joel, you want to kick off?
Just thank you, everybody. I enjoyed this.
Thanks, Joel. Bonnie?
I think for patients to give different things a try what works for you. Different approaches work for different people.
Good point. Julie?
Thank you so much for this opportunity this morning. I hope you all will look at the great resources that are on the NSDA website. They have done a fabulous job of pulling together contact information, and they keep you up to date on the latest and the greatest on treatment and researchers out there that you can be in touch with, as well as the experts you can reach out to.
Great. Thanks, Julie. Michelle?
I just want to say thank you for having me on the panel, and it's always nice to see you, Charlie and Kim, and to meet some new friends in this area of research and these medical conditions. So I'm looking forward to learning more about all this information and how to process this. So thank you again for having me.
Fantastic. Great to have you join us, and I look forward to working with you. Erik?
Yeah, thank you, Charlie. It's good to see you again, and Kim as well. I haven't seen you since one of those seminars, I think in the DC area quite a few years ago, but it's nice to see everybody back here. For those that are interested in my experience, SLAT-R, with the SLAT-R surgery, I actually kept a surgical journal, and you can see that at Spasmodic Dysphonia Surgery.com. I have voice samples, and I document the whole thing, and especially the year-long recovery for those of you that are considering it. So thanks again. This is a great event, and I appreciate it.
Thanks, Erik. Appreciate it. Good to see you as always, my friend. Bruce?
I just want to echo your comments, Charlie, about the dedicated healthcare professionals that we have available to us. I think the last panel referred to it as a smorgasbord of options, and I just encourage people to get to the table and try things. Different things do work for different people, but there are things that I think everybody's going to find something that's going to make it better.
Good point, Bruce. So we're going to call this a wrap, and I want to say thank you and my deep appreciation to each one of you panelists for participating. Great discussion, and just appreciate all you guys, all you do for us. So take care. Thank you.